Oh, Erin, you just need to unmute your microphone there.
Perfect. So our next presenter is Dr. Celine Hewitt. She's a pediatric endocrinologist at the St. Justine University Teaching Hospital in Montreal, where she's also the acting chief of service. She's a longtime volunteer with Diabetes Canada and was one of the authors of Diabetes Canada's position statement on recreational cannabis use in adults and adolescents with type 1 and type 2 diabetes. Thank you for joining us today, Dr. Hewitt, to talk to us about cannabis and diabetes.
Thank you, Erin. I'll put my slides up first. So thank you for this introduction. This would probably be my shortest stay in New Brunswick, having spent...
Yes? I'm actually not seeing your slides yet.
Okay.
So just to confirm, I think there's that white window where you'd select, and you might just have to press share after that.
Okay, let's start again. And this way. Tell me if it works.
I do see your slides now. Thank you.
Thank you, Christian. So, hello, everyone. Thank you for this invitation. Hello to everyone I know and all those people I can only see virtually or not. This will probably be my shortest stay in New Brunswick ever, having spent most of my summer vacations as a young person in the village of Maisonnette near Caraquette. So today we're going to talk about digging into the weed. Hopefully not digging too much into the weed, but there are indeed effects of cannabis on diabetes, and I think it's worth going there. So I would like first and foremost to expose my disclosures. I do act as a principal investigator for clinical trials in pediatrics, and here they are. So today I will briefly describe some of the forms and compounds of cannabis and their health effects, and we will go through the evidence around the deleterious effects of recreational cannabis, name some of the findings of the position statement that was published more than a year ago already, and finally try to go with you through some key points and practical solutions to address cannabis use in your patients living with diabetes. Now, where does this all come from? It all comes from the fact that starting in October 2018, Canadian citizens aged 19 and more, 18 years in Alberta and Quebec, were legally allowed to consume cannabis for recreational purposes. So this talk won't be a talk about how we could use cannabis to prevent diabetes or to help treat some of the complications and morbidities of diabetes. It's very important to notice that. It will be on some of the consequences on diabetes of using cannabis. So just to make sure, my kids have provided me with help on this one. During this presentation, I'll be using the word cannabis. And if you're used to some of the words named there, marijuana, bang, hashish, hemp, kif, charas, ganza, sinsemilla, etc., well, free to do so in your mind. My kids always have a big outburst of laughing when they hear me tell these words. So here's the situation right now. It's legal in Canada. And what do we do about it with our patients living with diabetes? So on this slide, you will see the reported percentage of use of cannabis in the past 3 months, pre-legalization and post-legalization as well. So before the act came into play in Canada, there were roughly 15% of adults claiming that they were using cannabis. 1 year into the act, actually more than 1 to 2% increase was observed. And so where is New Brunswick there? Well, New Brunswick, before the legalization, was the incidence was lower than the reported average for Canada. And 1 year after, oh, well, New Brunswick was above the reported average. Now, of course, there are biases here because maybe reporting something that is the use of something that's not legal may make it such that one would not disclose. But I thought it was interesting for people of your province to see how you fared there. Use of cannabis is more frequent in men than in women. And also, the increase after 1 year was more perceptible in the age range of 25 to 34. Okay, so when we talk about cannabis, we talk about many different substances. So, because the cannabis plant actually contains more than 700 chemical compounds, and those that are associated with products that actually may have effects on health, there are 400 of those. This molecule is trans-delta 9 tetrahydrocannabinol. That was the most difficult part of my presentation, and I'm through with it. Okay, this chemical probably explains most of the psychoactive effects of cannabis. It's called THC, which I'll use for the rest of the presentation, hopefully not having to use the long word again. So THC acts by binding to special cannabinoid receptors that are, dispersed throughout the body. There are two types of cannabinoid receptors called CB receptors. And CB receptors type 1 are more so in the central nervous system. They're in adipose tissue, and they're in most endocrine organs. CB2 receptors are mainly for themselves in the peripheral nervous system and the immune system. So THC will bind to more CB1 than CB2 receptors. We will talk later on about CBD, the counterpart, which is thought to have medicinal effects, but that product doesn't really bind as well to CB1 and CB2 receptors.
Hi, Celine. I'm sorry to interrupt. There's just a bar at the bottom of your screen that says you're sharing your screen. If you could just hide, you can click hide. That's great. Thanks so much. Sorry.
Great. Okay, no problem. Okay, so why do people use cannabis? Well, THC can cause euphoria and stimulate many properties that may actually help in delivering good productivity, and also they are helpful in relaxing. One thing is for sure, the greater the concentration of THC that's being used, the greater the likelihood that its effects will be perceived. So if people go or buy online some cannabis, if they want relaxing properties, they'll use a product that's in the category of what they call indica. If they want stimulating properties, they'll buy a product that's in the category of sativa. We have to mention that if we compare the proportion of THC in cannabis nowadays compared to what it was 20 years ago, the content and proportion is much higher than it was 20 years ago, now being 50 to 20%. Okay, so what are the not so good effects of using THC? Well, it could possibly have effects on memory, cognition, motor function, reaction time, psychomotor performance, and also on mood, behavior, and physical sensations. When it really gets to its worst, sometimes it causes paranoia, anxiety, psychosis, depression, and exacerbation of psychiatric disorders. So it's important to know that some people don't have necessarily a nice trip using cannabis. Okay, some of the related compounds we mentioned before, CBD. CBD is cannabidiol. And THCV, I'll just avoid mentioning the name, but it's important to know that these two compounds are the ones that are reputed to have medicinal properties rather than psychoactive activity. The only problem is that a lot of the literature on these compounds is not as rigorous as the one we find for THC. So CBD, indeed, thought to be less psychoactive than THC. And the fact that you have CBD and THC in cannabis can actually influence the absorption of one another. So it's important to know the relative proportion when you buy something legally. I'm not so sure you would get the description if you buy it illegally. Good to know, CBD may, though, alleviate some of the side effects of cannabis. And of note, if products are used dried, they do not have notable effects unless they are activated. You have to put some heat. And finally, why do people have varying effects of cannabis? Well, as we indicated earlier, it may be due to the type of cannabis you buy. It can be due to the relative proportion of THC and CBD. It can be the amount of cannabis that's consumed. If you use cannabis on a regular basis, you probably will be more prone to show less effect. And the frequency of use to cause this varies from person to person. The method of use, mental or physical disposition, if you're very tired, and also the environment. If you feel like you're in a, going for a party, maybe the effect is greater, and other factors as well, which are not necessarily well understood. So after going through the potential effects of cannabis in general, why would we ask on potential effects on diabetes? Because of those psychoactive effects, indeed. So more than 2 years ago, Diabetes Canada asked us to answer 2 questions, to do a rapid review and come up with a consensus statement. The question that was being asked was, among people aged 13 years and older, either with type 1 or type 2 diabetes, what would be the effects of using cannabis on metabolic factors or diabetes complications, and as well on diabetes self-management behaviors? So we embarked in a collaboration with the Strategic Patient-Oriented Research Evidence Alliance, and this is a group of people financed by CIHR that includes scientists, patients, people in politics, and who actually review topics of interest. And we actually went through a search strategy to answer our questions with a very rigorous protocol. And basically, those studies that were pulled from the literature had to answer very strict criteria, so no case reports, and in as much as possible, studies that had many patients. So outcomes of interest that were asked for the study: metabolic factors, HbA1c, complications, and diabetes self-management behaviors as well. Each recommendation was reviewed, it was graded, and it had to be approved with a 100% approval rate, and finally went through an external review. Of the literature, we found nearly 2,000 quotes mentioning diabetes and cannabis. But after going through all the eligibility criteria, we ended up having 9 full texts to read, and then excluding, and the reasons are written there, excluding the articles which probably had been misquoted or whatever. We only ended up with 6 studies. These are the 6 studies. Most of them were done in the USA. Most of them were cross-sectional. We can appreciate that if you come up with a publication in 2016 to 2018 using something that's illegal, makes a prospective study ethically and morally difficult, maybe. Most of them were either single site or multi-sites. and most of them were funded from internal sources. We won't go through all these proportions, but the most important thing about these studies is that actually all of them included reports on diabetes, metabolic factors, but only one of them talked about potential risks for DKA. So, what would be the possible link between using cannabis and glycemic control? Well, there have been animal and human studies using stimulation of CB1 receptors with various compounds. And doing these studies, it was observed that beta cells actually died earlier using this stimulation. And also it was described that in brain and in fat cells, it increased appetite, promote retention of adipose tissue, and lead to obesity. So whether directly or indirectly, it was logical to think that use of cannabis could potentially affect glycemic control. So of the studies I mentioned, one author reviewed actually 5 other studies, and including more than 1,000 participants. And using cannabis, if a person is living with type 1 diabetes, systematically these 5 studies reported that there was a worsening of glycemic control. The problem with these studies was that the exact HbA1c were not necessarily reported because either they had bad control, good control, or they had 3 different categories rather than looking at through the spectrum of HbA1c. So this is one reason it was difficult to come up with, I would say, a more precise opinion of the relation between the use of cannabis and HbA1c. But there was one study by Akhterk where actually he did a retrospective study of people living with type 1 diabetes. And in that study, they compared people who were using cannabis to those who were non-users. And they found that there was a higher HbA1c in the users. But when they adjusted for insulin delivery method, the income and the age, they found out that the difference between the 2 groups was actually 0.4%. No difference in reported severe hypoglycemia events, though. So they concentrated more on HbA1c. Van Hoosen did a citywide study of health effects in various diseases. So for instance, in his basic population of 1.2 million, there was more than 1,000 people found to use cannabis living with diabetes, type 2 diabetes this time. And in that paper, in more than 1,000 people, there was a slight but statistically significant increase in the risk of having peripheral arterial occlusion, of having an MI, or renal disease. In another study by Helgeson, evaluating the effect of smoking cannabis on various potential comorbidities of diabetes in patients living with type 1 diabetes this time, they found that there was a higher albumin to creatinine ratio in that population. Going back to ARCTUC. ARCTUC discussed also the risk of diabetes, ketoacidosis, and type 1 diabetes. The retrospective study was made in such a way that they asked people over the past 12 months, how was your diabetes or how bad was your diabetes? And that was their primary outcome. And asking people who came to the hospital the rate of reported DKA, they found a nearly 2 times increase in the odds of having DKA if you have type 1 diabetes and you're using cannabis. Now, they postulated that probably one of the reasons why this may happen was that, well, you're more inclined to eat more, which would make your blood glucose higher. By itself, using cannabis could alter your gut motility, also lead to the fact that you would throw up more easily. But these, of course, are only hypotheses. And finally, in a study in Spain, using recreational cannabis in people with type 1 diabetes, those who used most frequently substances, and they were looking at cocaine, cannabis, and alcohol there. A lot of them had an increased rate of DKA admissions by more than 50%, more so if they used 2 or more drugs regularly. The hospital admissions was more than doubled in the users for DKA, actually. And in a logistic regression, they found that there was a higher probability of being even readmitted, even though you've had, the whole discussion of how to avoid having DKA again. So what about self-care? There's one publication we found done in both the US and in Canada in college students. 30 states in the US and in Canada, ages 17 to 25. So these young adults said that actually if they used cannabis, they were probably more prone to have a higher HbA1c, having less glycemic values within the target values, expected target values. And finally, independent of blood glucose testing and diabetes burden, that was found. So there were limitations in the publications. The most studies were results of questionnaires and were done at the time when using cannabis wasn't really legal. So this by itself is a limitation. But we did find 6 articles then. There was no independent or blind assessment for exposure outcomes, and they were not well documented, very difficult to document it, as well as the frequency of use. Nor CT was found, even though some studies concentrated on comorbidities, we had no idea of how more rapidly they developed or not. And finally, the scope was very limited because there was no consideration for broader physical or psychological impacts of cannabis. Well, since then, has anything else been published from Canada on the use of cannabis in people living with diabetes? From the Alberta Youth Experience Survey 2008, after we did our review, people in Alberta published this. So in the general registry, with more than 3,000 people, if we compare to adolescents living with type 1 diabetes, the numbers are here. Well, the use of cannabis in people in the registry compared to those specific youth living with type 1 diabetes, the proportion was pretty much the same. It's more the use of other illicit substances that was much less in youth with type 1 diabetes than in the rest of the youth in the registry. So this gives us two suggestions. The fact that if you don't ask the question, well, you'll probably miss, at least in youth, more than 1 in 5 patients using cannabis. And the second thing is also the odds of having a yes are probably greater if you ask about cannabis than other substances. So if you have to aim and you don't have much time, go for cannabis. Makes sense. And my colleague Harpreet Bajaj, when we presented this at the Diabetes Canada conference, was nice enough to pull some data from the LMC clinics, whereby declared use of cannabis, either in people living with type 1 diabetes or type 2 diabetes, gave a proportion of 9% for those with type 1 diabetes and 2% for people living with type 2 diabetes. Now, of course, this was only 2 months after the Act came into play, so hard to conclude. Other evidence since then, there is a project ongoing right now in Ontario, which was published, and it will have both explore quantitative and qualitative aspects of potential repercussions of cannabis on diabetes. One publication from the States, from the Type 1 Exchange Clinic Registry, where adults with type 1 diabetes reported use of cannabis. And finally, there was a sub-analysis in those who used cannabis for the potential risk for DKA. And the adjusted risk for DKA was 2.5 times increased then. So we're looking at, the odds of 2 to 2.5 in different references if there's no counseling. What are the key findings from the position statement that was published, and how can we actually address potential risks of cannabis use in people living with diabetes? The first recommendation that was made was, well, you should engage the patient on substance use on a regular basis using a non-judgmental approach. And as Mahatma Gandhi said, well, if you don't ask, you won't get it. So why won't people ask about use of substances? There was a survey done, it was a while ago, but I think it's it speaks for itself. If you ask physicians on how often they ask, if you ask patients on how often their physicians ask them about substance use, it's a dismal percentage of people who asked about these topics. Now, there may be various reasons why people don't ask about substance use from I don't have the time or I wasn't trained for this, but I personally think that being ill at ease with the topic is probably the major reason. Okay, so how could we implement recommendation 1? Well, there are tools. Tools exist as to how you should ask or address the situation about substance use. And there was one tool that was actually adapted. It's called the Bstad, in short. And it's very easy because you ask in the past year, how many times have you used one of the followings? Pretty clear in terms of the answers you should be getting. Easier than saying or asking, are you asking yes or no? How many times is like asking an adolescent, how many times have you skipped an insulin dose in the past few weeks? And another tool is the S2B1, which is, I would say, the progressive approach. In the past year, how many times have you used this? And then you focus, okay, you focus on specific questions dealing with these substances. How can we broaden the conversation about substance use? Well, these days it's more difficult to sit down, but at least eye-to-eye contact virtually, if you can do it that way. Easier to get answers if you ask open-ended questions and you let the patient talk about this, because sometimes they make big detours coming back to the answer. And let's not avoid the discussion when it's out, and let's be empathic. Recommendation 2. Well, actually, we can't recommend recreational cannabis if you have diabetes, because it may worsen your glycemic control. It may sometimes be related to complications, and it could lead to poorer self-care. Well, that's the recommendation, but let's not be blind. We know people will use cannabis nonetheless. So if we find out that they use cannabis, maybe one goal could be to drop on the frequency of use of cannabis as a first step. And so the first step would be to inform the patients of the potential side effects of cannabis on diabetes. Once informed, maybe they'll react to this. And after saying that no use is best, well, maybe cut down on the number of or types of cannabis that you use per day. Make maybe your joint last longer. This may be useful. Cutting down the tobacco, because when it's used with cannabis, the effects of cannabis may be prolonged and enhanced, at least when you're on the good side of things. Try to exercise. Endorphins actually can compensate for some of the good feelings you get with cannabis. Watch out for alcohol. It may actually decrease the perception of some of the side effects of cannabis. And finally, slowly cutting down. Thing is, a lot of people may get withdrawal. Withdrawal is more common in the first 7 to 10 days after stopping. So it's easier for some people to just, gently decrease their consumption of cannabis. Recommendation number 3, DKA. So DKA, we remind people that the 2018 guidelines has a chapter on hyperglycemic emergencies, and since this can happen, it's good to know that there is a reference somewhere to handle this life-threatening situation. So once the patient is admitted, well, yes, we'll treat DKA, wait until the person feels better. But we will inquire now more than ever whether they have been using cannabis and other substances. We will inform them of the potential risks, and we will tell them probably as to how this can potentially happen and why it happens. So for those who use recreational cannabis, indeed, it's better not to use it, but maybe discussion with healthcare professionals may be best to prevent readmission. Recommendation number 4. For adults with type 1 or type 2 diabetes who intend to use cannabis, individualized assessment and counseling should be offered to inform individuals of the general risks of cannabis. So this requires a very individualized, appropriate approach, because some people may already have complications, and this may be a different ballgame than having a discussion with an impulsive young adult who doesn't have complications as well already. So identification would be, identification of potential risk factors would be on the types, frequency of use, how well or not they understand the potential impacts, how well or not we can put an action plan into play to avoid problems, and finally, if their consumption is very, very high, maybe refer to people who know more about substance use than us. There are recommendations that were either published by Health Canada or published by the US government as to how to counsel people on cannabis use. It's always better to read ahead of time. The only thing is sometimes we're not really prepared for these discussions. And finally, I think it's important to offer education, not necessarily under the scope of a medical visit, but also in other circumstances. In the slides, you will see guidelines and recommendations and links to these. So finally, yeah, we published the first evidence-based guidance document on the topic of the recreational cannabis in diabetes. Slim literature, though, very, very slim literature. Hopefully it will provide guidance to how to approach substance use and to prevent some complications of use of cannabis on the metabolic health of your patients. It's going to increase nonetheless, so let's keep our eyes open. And there is a need for further quality research. Maybe this will change since this is now legal. Thank you. I thank Dr. Harpreet Bajaj, who was my colleague in writing the consensus statement. We have been exchanging since then some of our clinical vignettes. Patients always have a way of surprising us. And hopefully in the next few years, we'll come up with more sturdy data on this topic. Thank you.
And thank you very much. We do have a question. Wondering if you have any comments on cannabis and gastroparesis or anything you've seen about cannabinoid hyperemesis syndrome.
I didn't hear the end of your question. The cannabinoid and it was cut.
Okay, so either cannabis and gastroparesis,
yep.
Or anything you've seen with regard to cannabinoid hyperemesis syndrome or cyclical vomiting. Yeah.
Okay. As I said at the beginning of the talk, the literature search focused on the acute and less acute potential consequences of using cannabis, not on the potential effects on either aggravating or helping these other things. No, there was nothing published, to be perfectly honest. It was not the topic, it was not the focus of our search, but I can tell you there was none. But I shouldn't be answering this question because it was not a focus. We did go through the 1,500 papers, though.
And really, the big message I think that you're very clear is that there really is not a whole lot of high quality literature, you know, from which to make recommendations for sure. Yeah. And
but
I think the
adolescents, we've been asking adolescents more and more about substance use. Well, this has there's two ways of seeing this. They're telling us more and more that they are using it, cannabis, because their parents are buying it legally, and a lot of parents tell us that they'd rather have their children using legal cannabis. Maybe the other thing is that a lot of people weren't asking the questions before, so we have the impression that this is more common, which is not the case. I'm not so sure.
Do you have any comment on the incidence of cannabis use in people with diabetes versus kind of the general public?
The general public, I showed the Canadian data at the beginning. So in the, it's now averaging, depending on whether male or female, it's now averaging just a bit less than 20% across Canada. Whereas the closest we could get in Alberta was 20% in youth. And in the LMC clinics, it was 9% for the type 1, people with type 1 diabetes, and it was 2% in adults with type 2 diabetes. But then again, reported use. How candid will you be and authentic when you're asked the question?
Yeah. Truly, it's a question we'll, like you say, never really have a firm answer to. Kind of like asking about hypoglycemia in many ways,
Yeah.
right? We'll never understand the true incidence, probably.
Yeah.
Yeah. Very good. Well, I don't see any further questions in the question and Q&A box. Oh, here we go. Are there any studies you noted that covered the use of CBD without THC?
On some specific comorbidities of diabetes, there are, but again, it wasn't the topic of the search, but I can tell you there are.
Okay. Perfect.
I won't comment on the quality.
Yeah, gotcha.
Yeah.
Right. Well, thank you very much for joining us. And like you mentioned during your talk that perhaps one of the reasons we don't discuss it is, that maybe as healthcare providers, we're not as familiar or as comfortable as maybe we should be. And I think that your session today has helped us, be more comfortable. And we thank you very much for that.
You're more than welcome. I hope you have a nice end of a conference. Bye, everyone.
You. Good. And so now we'll go to break until 2:45. Please know that when you visit the exhibit hall, that this will be your last opportunity to visit the exhibit hall. So please be sure to visit our sponsors. Thank you.